Now, without any further delay, let's begin today's Business Call to Action webinar, Replicating What Works in Inclusive Business. It is my pleasure to introduce your first speaker today, and that is Tatiana Besarabova, Knowledge and Coordination Consultant for the Business Call to Action. Tatiana, you have the floor.
Thank you, Jessica. Hello, everyone. Welcome, and thank you for joining us for the webinar discussion addressing the question, how do we replicate what works in inclusive business? My name is Tatiana, and as Jessica mentioned, I'm the Inclusive Business Knowledge and Coordination Consultant for the Business Call to Action. I would like to thank our webinar partner, Endeva, and our community support partner, Business Fights Poverty, for their support in today's webinar. For those unfamiliar with the Business Call to Action, we are a multi-stakeholder initiative that was launched at the United Nations in 2008 with the goal of accelerating progress towards the Millennium Development Goals by challenging companies to develop inclusive business models that offer the potential for both commercial success and development impact. Business Call to Action is a unique multilateral partnership and is supported by the Netherlands Ministry for Foreign Affairs, Swedish International Development Cooperation Agency, UK Department for International Development, US Agency for International Development, UN Global Compact, and we are hosted by the UN Development Program. Today's webinar will discuss how inclusive businesses can replicate their business models, thus expanding their operations and sharing their knowledge with peers who can follow a similar path. I'm pleased to introduce today's speakers that include Tulsi Ravila, Executive Director for the Alliance Aravind Institute at the Aravind Eye Care System based in India, Enrique Coronado, the co-founder and board director, chief executive and financial officer for Porti Familia based in Peru, and our moderator today is Aline Kramer. Aline is a co-founder and managing director of Endeva and an expert in inclusive business. She has been researching and advising on inclusive business for more than 7 years. Since 2007, she has directed more than 20 projects for diverse partners, including the BMD, GIZ, UNDP, UNEP, and others. Without further ado, I would like to pass it on to Aline. Thank you.
Perfect. Thanks so much, Tatiana, for the kind introduction. And before I start, I would really like to thank BCtA for making this webinar happen, as well as the speakers. And of course, I'd also like to thank all of you for joining us today. Scaling and replicating inclusive business models is a topic that's really very close to my heart, and that's why I'm excited about today's webinar, and I'd like to tell you why this topic is so close to my heart. We all know that the promise of inclusive business is to serve 4 billion people that live on less than $1 a day. Over the past decade, we at Endeva have seen that a variety of organizations that have pioneered innovative business models, which aim to improve the living situation of the poor. These examples, as you can see on the slide, range from, for example, rural health shops to mobile banking or energy kiosks. And as you can maybe also see with the illustrations on the slide, we believe that these business models so far have remained island solutions. That is, many business models only work in one particular geography, serving only thousands instead of millions. To reach 4 billion people, we believe that we need to scale and replicate these inclusive business models, because only through replication, of course, we can diffuse the many great innovations out there. However, to support replication, we felt that a better understanding of this topic is needed. We not only need to understand better how replication works, but also what's missing to foster it. To address this question, we wrote a study on replication, which was supported by the German Federal Ministry for Economic Cooperation and Development, or short BMZ. And on the slide, you can see an illustration of the research process that we went through. We basically started with desk research, then interviewed a variety of businesses and stakeholders, analyzed these results, and came up with key recommendations and action areas. One of the key insights of the report you can see on slide 5, which is being shown. We realized when talking to enterprises that they choose 2 paths to replicate. Either they expand or they disseminate. On the left-hand side, you see the expansion models. This means that basically inclusive businesses choose to replicate themselves, either through creating branches or they join forces with others, creating franchises or joint ventures. But what's particular in this area of inclusive business is that many companies are also mission-driven. That is, they are open to, or actually they have a mission of course, tackling the 4 billion people at the bottom of the pyramid, and they put this mission up front, which is why they're open also to share their model with others. Some of them actively support their model being copied or adopted, and I'm very happy that we have Aravind as one of the perfect examples for this. And Susie, who's on the webinar, will shortly tell you more about Aravind's dissemination activities. And in the study, we also found that most companies first choose to make their model work in one location before they start replicating. And many times they start in a location which has favorable conditions. To give you one example, I'm sure you all know the story of M-Pesa in Kenya. Their mobile banking model has more than 15 million subscribers. The success was partly due to very favorable ecosystem conditions in Kenya. When replicating the model to Tanzania and South Africa, they could not expect to find these conditions in place. Quite the contrary, like many companies we talked to, M-Pesa faced challenges when replicating their model. On the next slide, you see a very high-level summary of these challenges. In the report, we clustered the challenges that we learned from companies we talked to, and one of them is information and knowledge. Many companies told us that they lack information on how to go about replication, what kind of standardization and adaptation would be necessary, for example, or what legal forms to choose. Or they simply lack market data about suitable expansion markets. The second challenge was finding the right people and partners for their replication efforts. For example, companies that set up franchises often face difficulties finding franchisees with the right skills, business acumen, and the understanding of low-income markets. Particularly, companies told us that the combination of the business and understanding of the context of poverty was a challenge when they looked for both people and partners. And the third challenge is obviously access to the right financing. It was by far the most mentioned challenge. For example, many companies we spoke to are open to disseminate their model to potential copycats, but then they lack the financing to set up training programs or facilities like the one Aravind has. However, our study also identified organizations that stand ready to support companies in overcoming these challenges. Our study makes 12 concrete recommendations to them for how they can further improve the support provided to replicating enterprises. And the slide is the font is very little, as you can see. You're actually not supposed to read this slide, but the slide is just to encourage you to look at the study and download it. In the end, the idea of the webinar is not to present this long list of recommendations we developed. So the slide is really just to raise your appetite to take a look at the study. Rather, the aim of the webinar is, of course, to hear from the two very concrete replication experiences that we have. Luckily, we have Porti Familia and Aravind with us, and both are going to present, on the one hand, their business model, and then also their replication efforts. And after the presentations, hopefully, we would like to discuss the challenges they faced on their replication journey and how they overcame them. With this, we aim to inspire the companies that are on the webinar to engage in replication, and we also aim to show how other organizations that we surely have amongst the audience, like foundations, impact investors, academics, and other companies, or donors, can support companies to replicate. And yeah, on the last slide, you see my email address and also a link to download the study, but don't bother about writing all of this down. The slides will be provided, or a recording of the webinar, better said. And yeah, if you have any questions on this, you can also approach me in the chat. But enough about the study and myself. I'd like to give the word to Enrique and ask him, to tell us a bit more about himself, about Por Ti Familia, and about why replication matters to him. Thanks a lot.
Hello, everybody. Hello. Hello, everybody. My name is Enrique Coronado, and I am the CEO and co-founder of Por Ti Familia, and we have the mission to develop a high-quality primary healthcare model that is sustainable and replicable in emerging sectors. And as you can imagine, that is a very, very hard task. Our vision is to become the most admired primary health company in Latin America for our reach, our sustainability, and our social impact. Now, let me tell you a little bit about myself. Well, I did all my studies in the U.S., and after 10 years living abroad, I decided to come back to Peru to start a company where I could use what I had learned and the network I had developed in a venture through a venture-backed company that would benefit not only that would have a double bottom line, so it would be benefiting the people as well as would be building a sustainable business. As you might imagine, this is something very, very hard to do, and I'm going to try to let you know a little bit about my experience in the Q&A part of the question. But before, I'll tell you a little bit about our model. So basically, the way that we want to provide high-quality primary healthcare is through combining three services. So a pharmacy, doctor's office, and a lab. And we realized that actually integrating those three services was quite a very, very hard task. We were trying to build one business, integrating three other businesses, and we had a very, very tough time to learn it. So we decided that we needed to run a hub and spoke model. So the idea was to be able to enter into the communities with a very versatile model with infrastructure as the one you can see on the left that we called Mi Doctorcito. Mi Doctorcito is the community doctor. And in this model, we would have just primary care physicians and a pharmacy in the front that would basically serve a certain number of people in a certain community. These people wouldn't have to travel far or to get basic services, but these people also would need further services of secondary care, and we designed a second location which we call the hub, and that is surrounded by all these spokes, where we provide further services so that we can complement the needs of the healthcare needs of a certain size communities. Our value proposition, is the following. We basically do product and service bundling. We cross-sell medicines and doctor consultations, and that's how we make a profit. We're affordable and convenient. We by integrating the different businesses, we can provide better quality at affordable prices. And as I said, with Mi Doctorcito model, we can be located within the communities in a very low cost, simple low cost with modern infrastructure. And in order to integrate the whole hub and spoke model, we basically used technology, something that the people that we serve weren't used to, and we basically implemented electronic medical records. We implemented the logistics and commercial processes within the IT systems in order to be able to predict the demand, because we needed to have efficient operations. So the first thing we did was to build a team. That was quite a hard task, because convincing people of running or working in a company that was innovating, that was basically breaking some of the perceived concepts that we had in healthcare in Peru was quite hard, but we actually were able to do it. We had to learn the pharmacy operations. You know, there's logistics behind this, managing inventories, perishable inventories, and being able to integrate that with the rest of the business, you know, with the doctors and also with the diagnostics. So basically, I want to explain how this works. So in Peru, most of the people self-medicate, and our thesis is that people that go to self-medicate, you know, we could offer them a first free doctor consultation. They get invited to try the services at the doctor's office. Then the doctor provides a diagnostics, probably some additional examinations that could be imaging or lab works, and then the patient receives a prescription that could get filled at the doctor's office. But this wasn't enough, you know, attracting people via the pharmacy was very, very hard, because we had to compete with other pharmacies that had much more experience than us running a pharmacy operation. So we had to implement social impact marketing programs and starting to change how people thought about their healthcare. And we realized that, you know, people were very reactive towards their healthcare, and we needed to, in order for them, or in order to build a business, you know, and benefit the community, we needed to teach them how to take better care of their health. So we started with some social impact marketing programs, preventing and teaching about cervical cancer, and that got us opened the door within the communities, because we also discovered that most of the people that were making the decision in their households were women, and actually young women between in their 20s and their 40s. So, well, we've been doing that for 5 years. We built a 5-location network, and we perfectioned our processes. We were able to provide, with Mi Doctorcito, especially less time and more effectiveness in the treatment of healthcare. However, there was a big challenge to scale. We raised, just to give you some background, we raised around $4 million to start the business and to develop the operations, but we couldn't raise any further capital, because it is we had developed a very capital-intensive business, and we had to look at a different way of scaling, you know, a brick-and-mortar business. So we're basically looking at this moment into franchising. We're looking further into technology, and maybe now I would like to switch to Aline. She was going to ask me a set of questions, and I'll try to respond to some of the challenges that we've faced, you know, in order to be able to replicate our business at this time.
Perfect. Thanks so much, Enrique. Yeah, everybody, we thought we make this a bit more interactive, so we planned an interview-style proceeding for the rest of the presentation. Thanks, Enrique, for sharing your model. That was really, really interesting. Yeah, you just mentioned it. I mean, you mentioned one challenge is to find access to financing for your growth. And I wanted to ask you, what other challenges do you face, particularly preparing to your model for replication? You've mentioned that that you are choosing a franchise model for your replication efforts, and I assume this requires some standardization, some capturing of your model for the franchisors, or some quality control that you're putting in place. Can you let us know a bit more about the challenges and how you go about this? Thank you.
Yes. Yeah, sure. We needed to, when you start a business, you know, at the beginning, you have to be able to allow some level of this you have to allow some mess to happen so that the business grows. But when you want to replicate, this mess has to be fixed. So we needed to find a way to be able to provide or to provide the opportunity. Our franchisees would be doctors, and or our doctors, sorry. So we had to provide them with all the tools for them to run their own businesses. So we decided to run a framework with 4 basic elements. The first one is to be able to ensure this the franchisee to attract demand in a standardized and predictable way. The second one, they had to be able to control the rhythm of their business, as we had been doing with the IT systems that we had implemented in our in the locations that we run ourselves. Number 4, they had to be able to control their costs, because you cannot franchise unless you provide a business that is, or you sell a business that is profitable. And number 4, that was number 3. And number 4, you have to be able to control the quality of the product or service that you are providing. So, we've worked around almost 6 months in putting all that down into a certain number of documents, and to be able to provide all of the information to the doctors so that they could run a successful company. But that wasn't only a challenge, to do so, to firstly to fix that mess. The second challenge was to convince people that this is a viable business. But how could we convince someone if we were running our business in a disorganized manner? We had to run it as a franchisee. So we needed to change how people thought internally in the organization, so that our potential clients would see that they could also be able to run a franchise on their own. So that was definitely quite a challenge. In Peru, or at least in Lima, where we're present, it's very difficult to sell franchises because that market is very it's very early. It's still very early on in the franchise market. So you need to look for partners. You need to look for associations of doctors. You need to look for different ways to replicate your business in a fast manner, and in a manner that it won't cost the company any further, but you still need to show growth. So basically, people and finding partners was quite a challenge, Lynn, I would say.
Yeah, so this again resonates with what I mentioned before, I guess, the findings from our study, that finding partners is in fact a challenge. What did you do to overcome this challenge? Or do you have any insights for our participants on how they should go about finding partners? Did someone support you in this, or were there any networks that were fruitful for you?
Yes. It is very important to, for example, to work with the multilaterals. The Inter-American Development Bank has been a great source of for us to connect us with different partners. Microfinance institutions that are interested in expanding their models or trying a different business model with their existing client base. There's also some other industry-specific associations that should be reached. And it's amazing how people, once you have a model that works, they welcome innovation. At the beginning, it's very hard. But then it becomes very easy once it's working, and it can, and you can, and the risk becomes it's lowered, and predictability is actually a key ingredient that your business now has. So basically that.
Perfect. Yeah, thanks. Yeah, I mean, that's what we heard in many interviews, that of course at the very beginning, you called it a mess before, that then becomes structured and structured. And of course, as you start your replication journey, it's the time when you need to standardize things, as you explained with the framework that you provide to franchisees. I wanted to also dig in a bit deeper into the financing challenge that you mentioned before. I mean, we've heard this a lot, as I mentioned already. You know, when I talk to impact investors, they always say there are not enough investable business out there, or not enough businesses that have the capacity to absorb capital. Now I hear from you, you have a model in place that is actually working, but you have challenges to get the right financing. What are the reasons for that, and you know, what could be done to solve this gap from your point of view?
Well, I guess that our approach was a little bit different. We first needed a lot of financing in order to develop the model. So first, the first thing that I've learned an entrepreneur has to do is find the right product market fit, and that takes a lot of time. It takes a lot of resources, and it takes a lot of energy. And that's what we spend money on. You know, it took us around 5 years to do so, and as I said, around $4 million. Now, we would have liked to do it in a least expensive way, but I guess, you know, there's a learning curve, and it takes time. It costs a lot of money, and in emerging markets, you know, what you see 5 years or the market that you have seen 5 years ago is not the same. It's evolving as quickly as the venture is, you know, until today. So, you know, getting or having the clients or the client's perception on the business, or in our case on their own healthcare, or having a demand prepared for a new business model takes a lot of time, and it also takes a lot of luck. You know, you have to be able to predict and to have passion and to persevere. You know, it's the only way. We made a lot of mistakes, but we ultimately were able to produce a model that was actually viable. However, you know, we couldn't, you know, the right way of being able to attract further capital is to provide a return to investors. So it goes against the thesis of investment. You know, to keep investing more and more funds to grow, we had rather to pivot and to find a way to build on what we had developed, and build and find a strategy to grow faster with what had already been built. So right now, the investors that we're trying to find are not institutional investors, but rather private investors that want to run their own businesses. In this case, are doctors. So we have designed a business for doctors, and we're allowing them the possibility to run their own facilities in a predictable manner. So, and be part of a network and of a brand that could also drive in traffic. At the same time, sorry. At the same time, we also you know, it was very hard to change the perspective, not only of our franchisee or franchise clients who are the doctors, but also the patients, because you know, you need to be able to the doctors that will now that are now franchising will have to communicate this new concept to the patient, and it's basically how to take better care of their health. You know, they cannot just sell for selling, but actually giving the tools to the people for them to take control of their own healthcare. So yeah, it's switched now in terms of the challenge of financing. We're not looking any longer into social investors, but rather into private investors that want to run their own businesses and want to start their own businesses.
Got it. Yeah, thanks for clarifying. And before we switch to our next presenter, I have one last question for you. So, of course, from what I hear, you are planning to replicate your model further. Which kind of support would you need and from whom to be able to do this faster and better?
Well, we definitely need, you need to be very you need to have a lot of knowledge of the industry, and especially if you're planning, in our case, we're not ready yet to go internationally within Latin America, but even if we want to go to a different parts of the country, you have to have the right contacts there to be able to develop a business, and to adjust it to the type of situation or to adjust it to the community there and to the demand there. So having very close ties with the government is very important to understand what they're doing in healthcare. Having very close ties with current market participants within those areas where you want to replicate is very important, and having and also it's very important the reputation you have within, at least in our business, with the physicians community. So being having very good ties with the College of Physicians here in Peru that would be introduce you to the different chapters, within the different provinces in the country is very, very important. So just having a lot of knowledge within the industry.
Perfect. Thanks so much. And I guess we come back to you, Enrique, in the Q&A session. And with that being said, I'd like to invite all the participants to please type in questions in the chat. We can all see them, and we will actually try to address them. So if I can already pick some of your questions up when I interview the speakers, then I'd be happy to do that. But first, thanks so much, Enrique.
Thank you.
And I'd like to give the word. Thanks. I'd like to give the word to Tulsi, who's going to present us Arabat ecosystem and their replication journey, which is, I believe, a bit more advanced already.
Thank you, Eileen. That was quite a fascinating presentation by Enrique, and I want to really thank him for it. I would like to spend a few minutes about the work that we do, a little bit about the model itself, and then a bit more about the replication process, because we have done a fair bit of it. So first, to give the context, we work in a very narrow space of eye care, because the reality is that literally every fourth person is in need of some form of eye care. So if you take India, we estimate anywhere between 250 to 300 million people as needing some form of eye care. Could be something as simple as a pair of glasses, or something more complex which requires surgical intervention. But then when we do the assessment in the market, we recognize that less than 15% have been treated, and they tend to be largely urban and the affluent and the well-informed. So this is the kind of the context in which we came into existence in the year 1976. This was started by Dr. Venkataswamy. Because his name is long, everybody used to call him as Dr. V. He retired from the government service, and then this whole project kind of grew very organically after his retirement. So we started off in a rented house, which had about 4 bedrooms converted into a 11-bed hospital. And we kind of established a self-imposed tension. One, to say that we had to solve this problem of blindness, where most of the people would not be able to pay for the services. But at the same time, we said that we have to be financially self-reliant because, largely because we failed miserably in raising charity money, and we felt that we have to make it work. And we also recognize that you can't really scale and sustain if you're depending upon a grant or donations to run the core business. So as we went on with our work, our core focus became the non-customers, I think for 2 very obvious reasons. When I say non-customer, what I mean is these are people who have an eye problem or can benefit from some intervention but are not seeking it. Since this group constitutes 80% or more of the market potential, we thought we should, focusing on them, we would get better returns. And it is this focus which will also really address the social angle of the whole challenge. So we did several things, which I'm not going to go into great detail, but today we have grown to be a fairly large organization. Like last year, we had about 3.3 million outpatient visits through multiple sources in the hospital, us going out to the communities, primary eye care centers, and so on. We did a bit under 400,000 surgical and laser procedures, about 500,000 spectacles were dispensed. And of all the total workload, about 50% was either completely free to the patient or very steeply subsidized. When I say steeply subsidized, to give a feel, a modern cataract surgery, the patient who is subsidized would pay about $12. And as we worked on this model, we also built it in such a way that it was financially viable. As the volumes grew, our margins also increased. Like last year, we had a fairly substantial surplus. We had an EBITDA of about 30-odd%. And you can see that the full paying patients are only 45%. A third of the patients got their care completely free, and 22% paid the subsidized fee. And today we are in about roughly 66 locations, 5 large hospitals, each of which see about 1,000 to 2,000 patients, 5 secondary level hospitals which see maybe on average around 250 patients. We have 6 community eye clinics which are staffed by ophthalmologists, and a very rapidly growing network of primary eye care centers which are staffed by technicians supported by real-time telemedicine, EMR, and so on, where they on average see about 20 to 25 patients a day. So today, on an average day, we see about 10,000 patients, do about 1,500 surgeries across the system, do a lot of outreach and bring patients in for surgery. We are very, very significant training center. I mean, a lot of our HR comes through this pipeline of training. So we more or less done some backward integration. And this essentially is our model. And this is what we kind of got on to replicating. We chose to replicate, one, because we had set our mission as eliminating needless blindness, and we recognize that we won't be in a position to do it all, and neither should we even attempt that. So we wanted many other people joining this mission, but then doing it in their own way. But then we said that we can share what the best practices or what we have learned in this journey of building our model. And then we took over time, this approach started organically about close to 20 years back. So over time, different approaches emerged. So looking back, we did several turnkey projects towards replication. So in this, we did, other than owning the hospital, we pretty much did everything, from designing the hospital, which was built by the client. We kind of did recruitment from the local area, selected staff, put them through a year or more training as the building got built. We managed it, put in all the technology. Then after running it for different periods of time, varying from 3 months to 3 years, we handed over to the client once they were comfortable. This is the most involved approach of replication, obviously very resource intense kind of an approach. At the other end of the spectrum is largely consulting and mentoring with a focus on building organizational capacity. I'll just go over that in a bit of a detail. And then following this, we supported the whole replication process by lots of training activities, which are, these are not basic training, but then continuing education or skill development to meet some specific needs or to kind of build somebody in a specific role. And then we continue to do monitoring on a monthly basis. So in terms of the replication process, or what we call as capacity building process, it starts off with selecting the hospital, which in our case, we depended in the early days till about, say, 4 or 5 years back, largely on funding agencies who were supporting many hospitals in different countries. So we went to them and said that we'll be able to put their own partner hospitals into a process which would further leverage their investment or their grant which they are giving to those hospitals. And we worked predominantly with not-for-profit hospitals because they also had a social mandate. So once we picked a hospital, we focused in understanding them, doing a good situation analysis by visiting and spending anywhere between 3 days to a week. And then we brought to our hospital in Madurai a team from each hospital, which we identified during the site visit. Largely, I mean, it would consist of people who can make things happen. The head of the hospital, the chief ophthalmologist, the administrator, and so on. And during the week or 8 days that they spend with us, we help them set a vision, stretch goals, help them recognize the market potential, their own capacity, and then develop very specific strategic action plans. And then following that, they go back, and then we make a couple of site visits and help them in the implementation, and then do continuous monitoring and feedback. And I must also add, in this whole replication process in terms of financing it, the client doesn't pay anything. So we raise the grants, and some of the support also top-up comes from our own resources. We raise the grants, and then we pretty much give this away free to the client hospitals. In terms of during the mentoring and the strategic planning, we focus on a few key areas where we go do a real deep dive. The primary one is on the demand side. Now, we help them recognize what they should do to want to have patients come into the system, either the hospital or outreach, and then how do they keep them and make sure they complete the treatment loop, from diagnosis to surgery to follow-up. And then on the cost front, we designed all our systems and processes by looking at the total cost, not just what the hospital has to spend, but also what the patient also has to spend. So this makes the whole process very efficient. And obviously, we need to make sure that the patient gets the best possible outcome and have a good experience. So all these strategies relating to quality, both clinical and non-clinical. And all of this, because we are in the realm of eye care, where we today pretty much taken care of most of the preventive aspects. So what is left is all curative. So this has to sustain over time. So we help them recognize that and then help them explore how they'll maintain the HR pipeline, make sure the services continue to be relevant, and then also remain financially viable. And then in all of this, the most critical part is the mindset. So the focus, how to help them focus on the purpose and get into the change process. So this replication process, which we monitor quite closely, has been quite rewarding. This is the results of a sample of one continuous cohort of about 60-odd hospitals, which we did in the early days. Within the 12 months immediately following the capacity building or replication process, their volumes jumped up by over 50%. Their cost recovery they started off with about 58% cost recovery through user fees, jumped up to 90%. This came out of significantly high jumps in productivity and use of resources. And we have been doing this across the whole country. A lot of these hospitals are from India. About 240 or 50 hospitals are from every part of India, as well as in Africa, a bit in Latin America, China, and so on. So this has been our experience with replication. In the interest of time, I didn't go into all the details, but hopefully we can bring out some in the Q&A. Over to you, Eileen.
Perfect. Thanks so much for sharing this. I'm a big fan of your dissemination activities, actually, and thus I have one question for you before we go to the questions from the audience. And just for time planning, everybody who may join in from other time zones, we aim to end at past the latest. So please stay in with us. And Toby, thanks again for depicting your dissemination efforts. I wanted to ask you, what would you advise other companies that plan to disseminate your model, their model? What tips can you give them? What was crucial for you when setting up LICO? And what should they not miss doing?
Yeah, so what we have learned in our replication model is that what really ensures success is the leadership of the client organization. Now, how available they are, how engaged they are, because what it needs to come into improvement or do this well is really a change process, which is driven by, on one hand, a very powerful vision and a lot of passion. And those things come to play only if the leadership is really engaged with the organization. I say this because a lot of nonprofits are headed by leaders who do this for most part as a part-time. Like in our country, there are lots of eye hospitals are run by the Lions clubs. So the head of the hospital is the Lions Club president, who of course has other things to do. So his engagement with the hospital is not very intense. No, so then obviously the change in other things happens much more slowly. So if it is one single advice, I would say that when you choose your partners, choose them for that leadership bandwidth as well as some management bandwidth, which of course can be developed, but developing leadership bandwidth won't be possible. So that has got to be a given. Yeah.
Perfect. Thanks so much for this very good presentation and also your answer to the question. In the interest of time, I'm switching now to the questions from the audience, and I invite again all participants to post questions that you have to all the speakers. One question we had was very basic. Someone asked to provide a definition of inclusive business, and I'm sorry I didn't do that from the beginning. The way we define inclusive business is business models that address low-income consumers or producers, that address basically poor people in developing countries and include them into their value chains as consumers, producers, or entrepreneurs. And yeah, I do hope that's clear. And another person asked, also referring to our study, how we selected the enterprises that we interviewed. And I just wanted to mention we put together a whole database of inclusive businesses that have replicated already, and we wrote to all of them, and then we basically stuck to those that were willing to give us an in-depth interview and share their experiences. So both Procedure Media and Arrowine kindly did so. And yeah, thanks again for all the input that you provided.
Mm-hmm.
Then there was a question to Enrique. Enrique, someone wanted to know regarding the entrepreneurs of your franchise model. The person reckons that, of course, you need to find people that have that are both excellent health specialists, and on the other side are also good business people. And the person wanted to know how you do that, and if you provide trainings to them. And I would like to add a question myself to that. How do you ensure the impact of your model? You know, how do you ensure that they really care about treating the patients, and of course also including those that have difficulties to afford treatment?
Sure, Lialine. So first, with regards to finding the right business people to be able to buy into the franchise, I would have to say that actually in the case of physicians, you can actually, there's actually quite a I think more than we think, a very large pool of physicians that at least want to have their own doctor's office, you know, and especially many physicians have or do not have that great experiences when they work with insurances. We're starting to work with insurances lately, but at the end, they want to run their own shop. So, you know, we haven't, you know, we have found some physicians that already run, that already have businesses, and we're going with those physicians in order to minimize risk initially. And we are calling them master franchisees. The idea is that they could have 2 or 3, up to 5 franchises of the model. We've signed a deal with a company that, with a group of physicians that owns a company that does occupational healthcare, and they wanted to venture into ambulatory healthcare or outpatient care, sorry. And we're going with that first, while we are still developing a more powerful e-learning platform that will allow other physicians to be able to run their own shops. So basically, we're trying to find or to develop partnerships with people that are already in business and want to venture into a different segment within the healthcare sector. In terms of training, well, I've talked about the e-learning platform. It's nothing too complicated. It's basically very simple videos on how you should, we teach doctors on how to, for example, monitor the ledger, to how to teach nurses how to wash their hands and before taking care of any patients. So all of that is within a e-learning platform. In terms of the impact, that I think, and what Tulsi said in his presentation, and I wrote it down. It's very, very important, is to have a very powerful vision and to be able to pass it along. So what we had to do is to change our tagline, and you still see below Por Ti Familia, it says affordable quality healthcare, but we realized that really didn't mean much to the patient nor to the people that worked at our clinics at the beginning. It was mostly us pushing through, through processes and through training and through management to provide quality, affordable healthcare. So we decided to change our communication, the tagline of our brand, and provide it and give it a customer voice. So we basically, the way that we position it now is that we allow patients to take control of their own healthcare. And in every location, you see that it says it's actually so that's the concept, but the tagline says, "I decided to take care of my health, of my own health." So it sounds a little bit different in Spanish, but it's more a decision. It's that they decided to take better care of their health because they decided to invest in healthcare. And why we changed it is because we discovered that since people are at the moment very reacting to their healthcare, the first thing when they get sick, the first thing they think when they get sick is, oh no, I am going to miss work. I'm going to miss the ability to make money. So we try to change in all of our branding that you need to invest in their healthcare now in order not to invest in taking I forgot the word, but to invest later on in curing a disease because you didn't invest early on. And another key point, I'm sorry, I'm going all over the way, but another key point that we discovered is that if you think, when a person is more proactive towards their healthcare, it's usually when and it's usually the parents and especially the mothers when their babies are born. When their babies are born, they are very proactive on taking them to the pediatrician, to making sure that they are getting the right nutrients and so on so that they can grow. Once the child grows into a healthy person, then is when people become reactive. So we are, and just to address another question that I received on the platform, is how successful were we re-educating people? Sorry.
Before you continue, maybe we switch to Tulsi for a moment because there's been questions coming in for him as well, and then we can address additional questions that came into the chat. Is that all right?
No problem. Yes, of course.
Perfect. But thanks for the elaborate answer. That was really, really helpful. And Tulsi, there was a question we've learned from Enrique about his e-learning platform, and there was a question in the chat about the role technology plays in the replication journey of ArrowMind. And in addition to that, let me briefly check. There was also a question, and maybe you can address them together, or they're not directly linked. There was a question about the fact that you create competition and what that means in the success of the replication of your model. So if you can elaborate a bit more on that, that would be appreciated as well.
Yeah, so I'll try to be brief on both. One on the role of technology. I think it is becoming huge in the sense, on one hand, I think today technology can slowly be a substitute for, I'm not saying this in a negative sense, to the human skills. In the sense, the amount of skill that you need to do something, the technology can do a fair bit of it. Like, for example, assess the power of glasses. Earlier on, it's got to be completely done by the skill of the individual. Today, you have pretty good quality auto refractors, which can give you a fairly accurate reading. So on the clinical side, I think there is a lot of development, which is improving the quality, consistency, and efficiency to some level. Of course, there are investment considerations on that. And then on the non-clinical side, the use of IT for hospital management system. Now, you can actually mandate best practices through online management systems. So that's really wonderful, because you depend, the system kind of makes the individuals work smarter and better. So technology, I think, is a huge supporter of the whole replication process and happening well. On the notion of competition, I think as customer will all recognize that competition is being very helpful in terms of improving efficiency, in terms of improving quality, and so on. So even as providers, I think when we embrace competition proactively, and then in our case, we're actually promoting it, we are gaining a lot by way of the market development. There are more players doing good work. Everybody benefits, and we also benefit. The customer gets more aware because there are many people creating awareness. So when we're in a market which is hugely underdeveloped, like in our estimate in eye care in India, and is around, say, 20% market penetration. In Africa, it could be around 5%. Bangladesh, Indonesia, maybe around similar numbers. China, again, very low. So in a hugely underdeveloped market, you really want more people playing the game and playing it well. So that is what I meant by our own competition.
No, thanks for elaborating on that. But I can only support the question that is being asked. In talking to many inclusive businesses, they always face this trade-off, right? On the one hand, they are mission-driven organizations and want to spread or want to really achieve their mission, be it alone or with others. On the other hand, they are afraid of competition or because they've invested a lot in making their model work. And we all know that, of course, it's not an easy cash cow to provide products and services to the poor. A lot needs to be in place to make this profitable. Sometimes a lot of financial support is being given to the company. So there's always this trade-off, and a lot of companies I see afraid of creating their competition. So maybe as an additional question to you, Tulsi, what would you advise them based on what we've just heard from you?
Yeah, I would still hold the line. Of course, you will need the holding power is required for you to hold on till the market develops. And then if you don't have that capability, then I think it gets very tricky, to kind of work to promote competition. But then every field that if you reflect upon, like India really did not have a robust software industry till competition came into the local players by way of Coke or Pepsi. No, and that has not completely killed the local competition, or the local products. I mean, those who had the capability have actually flourished. No, so but again, I think we got to take it very contextually. So if you are entering a market which is hugely underdeveloped, and if you are the only player getting into it, you have a market share of 1%, let us say, not of the market potential. No, then it's very difficult for you to mature the market. No, you won't have the resources to kind of develop and drive the market. So you really need more people. So how exactly you do it, I think it will be business specific and yeah.
Perfect. Thank you so much for elaborating. There was another question I really found interesting. I think it's addressed to both of you. Someone mentioned that, of course, before replicating, you need to make sure that your model actually creates impact, and you need to structure your model to make it available to others. Or actually to replicate it yourself if you go for the expansion journey. And the question was, how important is monitoring and also reporting the progress and impact in this replication journey? And what have you both done to monitor and evaluate your model before replicating it?
Yeah, so I think fundamentally to be able to replicate, you really need to have a lot of evidence and a lot of standardization. I think both of them cannot happen without a good monitoring system. And without having evidence of impact, you really cannot even sell the idea of replication, or like what Enrique is doing for franchising and others. We will have to demonstrate this approach works with evidence. Not with intentions. So it's absolutely critical to do that before replicating. And then when you replicate again, you really have to be monitoring, because unless you do that, you really do not know what is happening. If it is not working with the franchisee or with the hospital, you really have to know, is it because of what inputs we gave them, or is it because of some other external reasons? And then in both cases, you will need to figure out how to fix it. So without this assessment, you really cannot have effective replication.
Thank you. Enrique, do you want to pick it up here on this question of monitoring and reporting your progress and impact? And then, of course, you can also address the question that you saw before in the chat.
Yes, I think that monitoring is very important, especially when you run or when you start an enterprise serving the base of the pyramid, and you need to monitor. And even you need to monitor from your costs. You need to monitor why people return. So what we did was, and I insisted a lot to my investors at the beginning, to be able to implement a technology that would be able to trace the customer throughout throughout our locations, and to be able to see how our customers behaved. So all of that needed to be reported, you know, as in terms of you know, through different monitoring reports, and that includes not only how many people you bring in, but how long do they stay, and that has to be transformed into costs. So it's very, very, very important, and from that you can build on some standards in order to then build a franchise. So that would be my take on that.
Perfect. Thanks a lot. The next question in the chat was, what you define as scope of replication, if it is the entire model or also enabling organizations with different models to take up on one or two processes. And I'd like to share a bit on, from our research. First of all, the scope of replication for me is both replicating an entire model or replicating what works from a specific model. And for Endeva, actually, this year, our focus topic will be replication, and it will address specifically the question you are asking here. Because we are asking ourselves also, how can we cross-fertilize models that we know are working? Because, of course, many organizations that, for example, supply devices to the poor face a distribution challenge, but also a lot of companies have gathered very good experiences distributing through village entrepreneurs, using NGOs as distribution networks, and so on and so forth. So what we want to do is, with our research, to document what works, and then also through the documentation to foster this replication, so that companies from different sectors can learn from each other and then, of course, replicate these business model components. And then the next question in the chat is actually again to both presenters, and I'm afraid it will be our second last question. So the person asks, Enrique and Susi, are your services accessible to all income groups in the areas you operate in? How do you determine fees for your services? And how much, say, a poor person in Kolkata can afford when she comes to your clinic? So, Susi, do you want to start? And Enrique goes next.
Yeah, so in terms of pricing, because like this, the topic said inclusive, our pricing model actually starts from negative, in the sense we spend money to enable the patient to access care, to zero to the market rate. You know, so we have the whole price range. And then we, in our model, we kind of leave it to the patient to decide what they, where they want to go. You know, if they want to go to get free care or pay for the services. And then, of course, we've created visible product differentiation in terms of different locations and different ambience and comfort levels and so on. So it's kind of left to the patient to decide. In terms of, I think the question that you asked was around spectacles. We do not provide medicines or spectacles free as a rule. So we only prescribe them, and the patients have to buy them. We invest quite a bit in counseling to make sure that they actually comply with that advice, and we also monitor that very tightly. And then in certain instances, we do provide the spectacles free, which is to school children, because we just want to make sure that the children don't miss out on following through. So I don't know if I covered both the questions.
Perfect, thank you. Enrique, do you want to share a little bit about how you make sure your actual target group gets access and not other income groups who might get good access to care anyways? Maybe a couple of words about that, and then I would like to have a couple of seconds to wrap up.
Sure. No, at the moment we don't have differentiated pricing. Our thesis behind that is that, well, at least in Lima, where we're present at the moment, we located we have our locations in the periphery of the city, where where our target customers live. But now we've opened a few locations in the center of the cities where our target customers work. And our thesis behind that is that in a city where you have a large percentage of the population as a target customer, they will be all over the city, actually, during the nighttime or in the afternoon at their homes, or during the daytime working in the central locations where where most of the companies and the work is. So you see our target customers everywhere in the city. So at this time, we haven't differentiated on pricing, and we make sure that we attract the right customers with our communications. Most of them are uninsured, and so we, for example, publish our prices at the front of the stores and our services as well. We know the type of services and the prices that our customers are willing to pay. That's how we're doing it at the moment.
Perfect. Thanks so much to both of you, and thanks to the participants for these very interesting questions. We've taken almost all the questions for you, but I apologize for the 2 or 3 that I couldn't take. And during the last seconds while I'm wrapping up, actually, I would like to get answers from the participants, not questions. So if you have any suggestions about how replication can be fostered further, type them in the chat. I would be really just interested in hearing your input as well, because I have the feeling we have a whole crowd of knowledgeable participants out there. And yeah, my actually very last question goes to Tatiana, and this is also a chance for her to wrap up and say goodbye to you. Tatiana, I'd like to know, how does business call to action actually support replication? If you can give us a couple of words about that, and then I'd already like to say thank you and goodbye to everyone. And Tatiana, you have the last word.
Hi, Aline. Thank you very much. And thank you very much to all the participants, the speakers, and also those that have tuned in to join the webinar and that have typed in their questions and stayed with us until the very end. So thank you very much for that. I just want to say that business call to action, our primary goal to support replication and the uptake of the inclusive business models worldwide and primarily in developing countries through sharing the experiences of the successes and the successful stories like these. And we are, in our knowledge and impact work, we would like we champion and we promote and highlight the success of our companies and member companies, and we're happy to share these experiences across different sectors and geographies and to help bring the successes from one region to another, from one sector to another where applicable. And so we will have many more events and many more opportunities to do so. So I invite you to follow us on our Twitter at BCtA Initiative and also on our website. And on our website, you will also find a link to the Guardian Sustainable Business Partner Zone, where Business Call to Action publishes a lot of materials. So please stay with us and please follow our path, and we hope to feature many more companies and many more successes in the future. So thank you very much for joining today.
Thank you very much.